Welcome back. Today, we are diving into one of the most essential skills in medicine, reading an electrocardiogram. Now, I know it can look like just a bunch of squiggly lines, but it's literally a rich, detailed message coming directly from the heart. And by the end of this, you are going to have the code to decipher it.
So, where did we get this powerful systematic method? Well, the approach we're about to break down comes straight from the fantastic resources provided by the experts at DearCat Premium Revisions. You know you're getting a clear, effective, and seriously well-tested approach here.
For so many of us, the first look at an ECG can be, well, pretty overwhelming. But what if I told you it's not about memorizing 1,000 different patterns? What if it's about having one simple, repeatable system that turns all that chaos into a crystal clear story about what's going on in your patient's heart?
All right, let's jump right into our systematic approach. Every single time you pick up an ECG, I want you to start the exact same way. We begin with the absolute fundamentals, rate and rhythm. You get these two right, and you are well on your way.
But wait, before we even think about the heart signals, we have to check the boring but absolutely crucial basics. Is this the right patient? The right date and time? And this is a big one. Is the machine even calibrated correctly? We're looking for that standard speed of 25 millimeters per second and a voltage of 10 millimeters per millivolt. If that's off, all our measurements will be off too. Okay, this slide is super handy because it gives you a quick tool for any situation. If you've got a regular rhythm, it's easy. Just take the number 300 and divide it by the number of large squares you see between two of those big R waves. But what if it's irregular? No problem. Just count up all the QRS complexes across the entire 10-second strip and multiply that number by 6. Simple.
And what number are we hoping to see? Well, for a normal resting adult, we're looking for something between 60 and 100 beats per minute. Anything higher than that, we call it tachycardia. Anything lower, bradycardia. This number is our first huge clue.
So how do we know if the heart's own natural pacemaker, the sinus node, is the one in charge? We just ask ourselves these three simple questions. 1. Is the rhythm regular? 2. Do I see a P wave before every single QRS complex? And 3. Is every one of those P waves actually followed by a QRS? If you can answer yes to all three, then boom, you have just confirmed a normal sinus rhythm. All right, we've got the rate and we've got the rhythm. Now it's time to zoom in. The next part of our system is all about decoding the actual waveform. We're going to analyze the individual shapes and signals that tell the deeper story.
And this right here is a brilliant little trick for figuring out the heart's electrical axis. You really only need to look at two leads, lead I and lead AVF. Okay, think of them as your two thumbs. If the QRS complex is pointing up or positive in both leads, that's two thumbs up. The axis is normal. If lead I is up but AVF is down, the axis is swung to the left. And if lead I is down but AVF is up, it's gone to the right. It is such a powerful shortcut.
Next up, let's look at the P wave. This little wave represents the atria contracting, and its shape tells us a lot. If you see one that's unusually tall, think of it as being stretched upwards. That points toward right atrial enlargement. If it's really wide and maybe even has a little notch in it, kind of like the letter M, that's a classic sign of left atrial enlargement. So what's the PR interval? Well, you can think of it as the communication delay between the atria and the ventricles. Normally, it should be pretty quick, less than 0.20 seconds. If it starts getting longer than that, it's a sign of a delay, what we call a first-degree AV block. And if it's super short, that suggests the electrical signal is taking a shortcut, bypassing the normal route, which we see in conditions like Wolff-Parkinson-White syndrome.
Now for the main event, the QRS complex. That's the big spike that shows the ventricles contracting. Its width is absolutely key. A nice, narrow QRS is normal, but a wide QRS tells you the signal is traveling slowly, maybe because of a bundle branch block, or because the rhythm is actually starting in the ventricles themselves. And don't forget height. Really tall R waves can be a clue that the ventricular muscle has gotten thicker, a condition we call hypertrophy.
Okay, deep breath, because now we've arrived at the most critical part of our interpretation. This is where we are actively hunting for the red flags, the signs of ischemia and infarction that can be immediately life-threatening.
So here's the crucial point. The ST segment should normally be flat. I mean, perfectly flat, right on the baseline. The second you see it elevated, your alarm bells have got to be ringing for a potential heart attack or maybe inflammation around the heart. And if you see it depressed or pushed down, that points towards ischemia, meaning the heart muscle just isn't getting enough oxygen.
And here's the amazing part. If you do see that ST elevation, the ECG can act like a GPS and tell you exactly where the heart attack is happening. Just follow the clues. If you find elevation in leads I, 3, and VF, you're looking at the inferior wall of the heart. See it in V1 to V4? That's an anterior MI. And finally, if it's in leads I, AVL, V5, and V6, that points to a lateral MI. This is incredibly powerful for guiding what we do next.
Right after the ST segment comes the T wave, which shows the ventricles resetting for the next beat. And this little wave is extremely sensitive to what's going on in the body. Sure, an inverted T wave can be another sign of ischemia, but what's really fascinating is that it's also a window into the body's chemistry. Those classic tall, peaked T waves are a huge red flag for high potassium, while flat T waves often suggest potassium is too low. And finally, we measure the QT interval. You can think of this as the total recharge time for the ventricles. Now, if this interval gets too long, it can seriously destabilize the heart's electrical system. It puts the patient at a much higher risk for a very dangerous twisting arrhythmia called torsades de pointes. It's a subtle measurement, but an absolutely vital one.
So we've gone through all the individual pieces of the puzzle. How does this all come together in the real world? Well, once you get used to applying the system, you'll start to see clear patterns emerge, and that lets you recognize critical diagnoses almost instantly.
See how it all just clicks into place? You see a rhythm that's irregularly irregular with no clear P waves? That's AFib. A really fast rhythm with wide QRS complexes? Think VTAC. A crazy fast rhythm but with narrow complexes? That's SVT. And remember those tall peaked T waves we just talked about? That's your big clue for hyperkalemia. Each diagnosis is just a combination of the things we just systematically checked off.
And that's really the whole point, isn't it? Reading an ECG isn't about guesswork or some kind of magic intuition. It's about applying a consistent, logical system every single time. That's how you turn what looks like chaotic data into a clear, confident, and actionable diagnosis. So the next time an ECG is handed to you, don't just see a squiggle. See a story that's waiting to be read. You now have the grammar and the vocabulary to understand it. The only question is, what story will it tell you?